The first slide presents the topic spasticity versus rigidity, accompanied by diagrams. This slide serves as an introduction to the comparison between these two neurological conditions. The images visually represent different muscle stiffness characteristics that will be elaborated on in subsequent slides. Understanding this distinction is crucial for comprehending these neurological concepts. This slide provides a clear distinction between spasticity and rigidity. Spasticity is characterized by velocity-dependent resistance to movement, often linked to issues in the upper motor neurons. On the other hand, rigidity is a constant resistance that doesn't change with movement speed, typically related to problems in the basal ganglia. Understanding this key difference in velocity dependence is crucial for diagnosing these neurological conditions. Moving on to the next slide, we see the conditions that are typically associated with spasticity and rigidity. Spasticity is often seen in patients with stroke, cerebral palsy, multiple sclerosis, or spinal cord injuries, indicating upper motor neuron involvement. Rigidity, on the other hand, is commonly observed in conditions like Parkinson's disease, which affects the basal ganglia. This slide helps connect these neurological concepts to specific disorders. Now, let's delve into the pathophysiology of these conditions. Spasticity arises from a loss of inhibitory control in the upper motor neuron system, leading to a hyperactive stretch reflex. On the other hand, rigidity is caused by basal ganglia dysfunction, resulting in constant increased muscle tone. This slide clarifies the underlying neurological mechanisms behind these two conditions. This slide focuses on the types of spasticity. It mentions the clasp knife phenomenon, which is a characteristic resistance that suddenly releases, and also notes the presence of flexor and extensor spasms. The image of a folding knife is likely used to illustrate the clasp knife phenomenon, where initial resistance gives way to sudden relaxation. This slide provides key characteristics to help identify spasticity in a clinical setting. Now, let's explore the types of rigidity. This slide distinguishes between cogwheel rigidity, which is characterized by a ratchet-like resistance, and lead pipe rigidity, which is a smooth, uniform resistance throughout the range of motion. The images of a cogwheel and a pipe help visualize these different types of resistance. Understanding these distinctions is important for accurately assessing and describing rigidity in patients. This slide presents a clinical features comparison between spasticity and rigidity. It highlights that spasticity is due to upper motor neuron lesions, is velocity-dependent, and affects specific muscle groups with exaggerated reflexes. Rigidity, on the other hand, stems from basal ganglia lesions, presents as uniform resistance, and affects both agonist and antagonist muscles without the exaggerated reflexes seen in spasticity. This comparison helps clarify the key differences in their clinical presentation. This slide shows the modified Ashworth Scale, which is used to assess spasticity. It provides a grading system from 0 to 4, where 0 indicates no increase in muscle tone, and 4 represents rigidity in flexion or extension. The scale describes different levels of resistance encountered during passive movement, helping clinicians assess and monitor spasticity. This slide presents the Tardieu Scale, another assessment tool for spasticity. It evaluates the quality of muscle reaction to passive movement, scoring it from 0 to 4, based on the presence and characteristics of muscle catch and clonus. The scale also considers the angle at which the muscle reaction occurs, providing a more detailed assessment of spasticity. It helps differentiate between varying degrees of muscle hyperactivity. This slide presents the Unified Parkinson's Disease Rating Scale, or UPDRS, which is used to assess rigidity. It provides a scoring system from 0 to 4, where 0 indicates the absence of rigidity, and 4 represents severe rigidity where the range of motion is achieved with difficulty or not at all. The scale describes the degree of resistance encountered during passive movement, helping to quantify the severity of rigidity in patients with Parkinson's disease. This slide presents a simplified rigidity rating scale. It uses a score from 0 to 4, where 0 indicates no rigidity, and 4 represents extreme rigidity where movement is almost impossible. The scale provides a straightforward way to assess the severity of rigidity, with levels describing the degree of resistance encountered, from mild to severe. Finally, this slide provides a management overview for both spasticity and rigidity. It includes physiotherapy, which involves stretching, positioning, and strengthening exercises. Medical treatments mentioned include antispasticity drugs and Botox for spasticity, while levodopa and deep brain stimulation are noted for rigidity. This slide provides a general overview of the approaches to managing these two neurological conditions. In conclusion, understanding the differences between spasticity and rigidity is crucial for diagnosis and management. We've covered their definitions, underlying mechanisms, assessment scales, and treatment options. This information provides a comprehensive guide for distinguishing these two neurological conditions and approaching their care effectively.